Good morning, everybody. Thank you for joining us. This morning, I have Dr. Sorrell, who is going to start in on our pre-transport series. This will be part one of a four-part series. So he's going to hit the ground running with some respiratory distress things and just some kind of some clinical management and a little bit more on how to recognize clinical deterioration for respiratory distress. I know there were several that won't be able to join this morning. Summer gets a little bit crazy, but again, we will have CE credit for everyone who joins and completes the evaluation. So I will post the link in the chat, but I don't want to put us off any further. So Dr. Sorrell, I will hand it over to you. Thank you.
Okay, Kelsey, can everybody hear me well, and can everybody see the slides?
Yes, sir.
All right. So when Kelsey asked me to put this presentation together and kind of described what the goals of it were, I really thought about the things that as the physician on the accepting end of thousands of transports, what respiratory issues are we most often accepting, and some of the topics that would be most helpful for physicians in smaller hospitals, community hospitals, rural hospitals, and to think about from a respiratory standpoint. This is in no way exhaustive from when thinking about all of the possible respiratory disorders that we see in the NICU, but this covers the vast majority that's going to be seen early in life. There are some rare disorders that we will occasionally see, but for the vast majority of patients that get transferred to us for the primary reason of respiratory distress, it's really a short list. It's 4 or 5 things, and so we're going to spend some time this morning talking about those things. If anybody has any questions, don't wait till the end. Just speak up right then. That way we can talk about it as we're going through that topic. So before we talk about abnormal respiratory status in a neonate, we really need to kind of talk about assessing a baby's respiratory status. So typically the normal respiratory rate for a newborn is 40 to 60 breaths per minute. But during the first hour of life, especially when they're making that initial transition from what is a liquid environment to an air breathing environment, rates in excess of 60 can be normal. You can oftentimes see mild substernal, subcostal, or intercostal retractions. Those can be present. Now, they can be abnormal, but sometimes they can be normal. And it's really due to an extremely compliant chest wall. Even term babies, and this is more so the case in preterm babies, they're not born with fully developed connective tissue, and so their chest wall moves quite a bit. And so what can be normal breathing can sometimes look somewhat abnormal if you compare it to a baby who's a few weeks old or a few months old. However, persistence of these retractions or worsening of the severity is suggestive of respiratory distress, so abnormal respiratory status. Again, nasal flaring can be normal, especially during sleep and especially during feeding. And again, if it persists, it can be a sign of distress. We oftentimes hear about and talk about grunting. What grunting is an infant's attempt to maintain FRC. FRC is an acronym for functional residual capacity. Technically, what FRC means is it's the amount of air left in the lung after full exhalation. The reason why that's important is because FRC is the primary driver of either normal respiratory transition or abnormal respiratory transition. If babies cry early on and take in quite a bit of air and open up the lungs, which helps push out a lot of fluid and maintain and develop good FRC, they're probably going to make that transition normally. If they don't, they may have respiratory distress. And so grunting is an attempt of the infant to push air in at the end of exhalation to keep those lungs open, which makes the next subsequent breath easier and attempts to make that transition normally. Now, if grunting is audible with every breath or excessive or persist, it can be a sign of respiratory distress. So breathing in the delivery room. Stimulation during NRP helps promote breathing and crying. It is, in my opinion, by far the most important thing you can do for a baby immediately after delivery. Warm, dry stimulate is the first and most important steps of resuscitation for a reason. Crying and breathing begins to the development of FRC. We already talked about FRC on the last slide. The other thing that's important to keep in mind is the assessment of oxygen saturations, in particular with the focus of NRP over the last probably 5 to 10 years about monitoring vital signs earlier and earlier. And even with the last update on NRP, looking at using a cardiorespiratory monitor in the delivery room, there's been I think a shift and more of a focus on using the vital signs to help guide resuscitation. Prior to, the 2017, 2018 update to NRP, we weren't monitoring heart rate. And before 2017, a lot of centers were monitoring oxygen saturations by using color. They weren't even using pulse oxes in the delivery room. But now pulse oximetry has become a mainstay of NRP. But it's important to remember that oxygen saturations are not going to be the same goals in the newborn nursery compared to what they're going to be in the delivery room. Fetuses live in what we would consider a hypoxic environment. The normal oxygen saturations of a fetus are somewhere between 55 and 65%. And so, as you can imagine, immediately after birth, when they begin breathing, begin pushing more oxygen into the lungs, it's going to take some time for the oxygen saturations to improve. And in fact, we don't really want to oversat them in the delivery room. We want those oxygen saturations to rise naturally and rise gradually. And this is sort of a goals at 1 to 10 minutes of life. The easiest way I think about it in my mind is if you start at 60 and add 5 for every minute. And that way, if you're 5 or 6 or 7 minutes in, the math becomes easy. So you kind of know where you're supposed to be. But at 5 minutes, when you're given that APGAR score, and you assess a baby who's, pretty pink centrally, maybe a little bit of blue around the mouth, a little bit of blue at the fingertips and toes, and their saturations probably aren't really now they can be in the 90s, low to mid to high 90s, but they don't need to be to still have good central perfusion and to be pink centrally. And even to get an APGAR score of 9, the sats really only need to be above 80% at that stage. So what do I mean by neonatal transition? So there's a tightly regulated system that begins the movement of fluid out of the lungs. It actually happens long before the process begins, long before a mom even knows she's in labor. There's hormonal changes that start weeks ahead, sometimes weeks ahead of the labor process, that begin the process of moving fluid out of the lung and begin to prepare for air breathing. And this system is achieved through what are called ENaC channels. So those are electrically gated sodium channels is what ENaC stands for. So during pregnancy, ENaC channels primarily move fluid into the alveoli. They maintain fluid within the alveoli, which promotes lung development. That's why in cases of oligohydramnios or early rupture of the membranes, we worry about pulmonary hypoplasia or pulmonary underdevelopment. And so alveoli need to be fluid filled during pregnancy for the lungs to develop normally. But again, in the weeks leading up to birth, there's a hormonal stimuli that changes the direction of flow of ENaC channels. So instead of fluid going into the alveoli, these channels switch directions and fluid begins to move out of the alveoli. And so this is a nice kind of diagram of seeing that fluid moving in the opposite direction from the alveoli into the pulmonary vascular and lymphatic vessels and into the interstitial space itself, as that fluid moves out of the alveoli and away from the lung. Now, the thing that's important to remember about this is if for some reason there is delivery without labor or early delivery without labor, this process may be in its early stages or have not started at all. And so you may be delivering a baby with alveoli that are partially or completely filled with fluid. And so they are not going to breathe normally. They are almost always going to have respiratory distress. This was the primary driver behind Marcia Dimes' push for no elective C-sections before 39 weeks several years ago. It was because of this process, because babies need time to move that fluid out of the alveoli in preparation for air breathing. So uterine contractions are thought to also compress the fetal chest further, promoting flow of lung fluid out of the lungs. That's why normal laboring process is important. About 50 to 60% of lung fluid is typically removed from the lungs prior to delivery. So the lungs are not completely dry at the time of birth, but they are mostly dry is the best way to think about it. And so remember, this amount can increase. So the amount of fluid removed can increase with a normal vaginal delivery, with a normal labor. And this amount can substantially decrease or be almost completely null with a C-section without any labor. And again, approximately 20 to 40% of the remaining lung fluid is absorbed following birth. This amount is also subject to hormonal dysregulation. So babies born to mothers with certain conditions are thought to be at risk for having increased lung fluid at the time of delivery, including moms or babies born to moms with gestational diabetes, chorioamnionitis, although there's some suggestion that chorio may, in some cases, increase retained lung fluid and in some cases decrease retained lung fluid. So that's somewhat controversial at this stage. And then other inflammatory processes can also increase the amount of retained lung fluid at the time of delivery. So the first and probably most common, and I think the one that everybody's going to be the most common with, is transient tachypnea of the newborn. And it's due to excess retained fetal lung fluid. And so what you're going to see clinically is pulmonary edema and pulmonary congestion. And it's due to inadequate or delayed clearance of fetal alveolar fluid. It typically resolves in 48 to 72 hours. The important thing to remember as we go through these, especially when comparing transient tachypnea of the newborn, respiratory distress syndrome, and congenital pneumonia, is that oftentimes in the early stages, so prior to 72 hours, clinically and even sometimes by x-ray, it's difficult to differentiate between the three. And so oftentimes the time course of improvement will make the diagnosis for you. It's not always clear early on that a baby has TTN versus RDS. It's oftentimes you're not going to know that for a few days. A baby who gets better probably had TTN. A baby who doesn't maybe had RDS. A baby who is still having respiratory issues 3 to 7 days after birth may potentially have congenital pneumonia. So the risk factors for TTN include premature or elective C-section without labor. There's a 2 to 3 times increased risk with an elective C-section compared to a planned induced vaginal delivery. Babies are also at risk if they're LGA or have macrosomia, maternal diabetes, maternal asthma, interestingly. Questions? Okay. Twins are at an increased risk of TTN. And then interesting, little boys are at increased risk of TTN versus little girls. Here is kind of the quintessential textbook x-ray of TTN. What you're seeing, the white arrows are suggestive of fluid in the minor fissures from retained fetal lung fluid. And then the red arrows are actually showing a small right pleural effusion, which is common with TTN. Oftentimes we don't see it, we don't look for it. We're oftentimes looking for that fluid in the fissures. Oftentimes it's in the right side between the upper and middle lobe. But pleural effusions are pretty common in babies born with TTN, although oftentimes they're small and self-limiting. Here is another x-ray of TTN. I pulled this one up because it shows two things. Again, the black arrow is showing that fluid in the fissure, but what you're also seeing in both the right and left upper lobes is significant pulmonary congestion and really prominent pulmonary markings, that white streaking starting centrally and moving out peripherally. That pattern is very suggestive of pulmonary congestion. So the symptoms of TTN are tachypnea. It's in the name. It's the most consistent finding. You can also see expiratory grunting, nasal flaring, retractions. Hypoxemia is common but less prominent with TTN, especially versus RDS. You can have some degree of CO2 retention, but again, not quite as common. It happens, but it's uncommon to have complete respiratory failure requiring either non-invasive CPAP ventilation, intubation, or mechanical ventilation. It's unusual with transient tachypnea of the newborn. Not impossible, but unusual. So from a treatment standpoint, antibiotics can be started, but I would highly encourage them to be discontinued early, especially if blood cultures are negative and the diagnosis is more clear. Really, the studies that have looked at transient tachypnea of the newborn have found that Lasix has no role in treatment. You can't really diurese your way out of transient tachypnea of the newborn. Antenatal steroids in late preterm infants have shown some possible benefit, but when deciding on antenatal steroids in late preterm infants, it's really a risk-benefit analysis because antenatal steroids have some side effects for the mom. And so in a very premature infant, an infant below 34 weeks, the benefits far outweigh the risk. So the benefits to the baby far outweigh the risk to the mom. But as you approach that late preterm age, it becomes unclear if the benefits for that infant really do outweigh the risk, especially in a mom who has gestational diabetes or pre-existing diabetes. There's been really good literature to suggest that antenatal steroids can push a mom over into DKA if she has pre-existing diabetes. And so you have to be thoughtful in when you choose antenatal steroids or suggest or recommend them to the OBs, because you really do need a clear benefit in that case. Postnatal steroids have absolutely no benefit, unfortunately. Interestingly, beta agonists such as albuterol have shown some possible benefit in small studies. It's not clear why, but it probably has to do with opening up of the alveoli, so dilation of the alveoli to allow for more FRC. And then delaying elective C-section is by far will by far improve your TTN rates more than anything else until after 39 weeks. Respiratory distress syndrome is our next disorder. So the old school names for it are hyaline membrane disease or simply surfactant deficiency. It can be due to either surfactant deficiency, depending on the gestational age at birth, or surfactant inactivation. You can see surfactant inactivation at any gestational age. It is most common with either a meconium aspiration or a blood aspiration in cases of swallow maternal blood. Sorry. Or from a pulmonary hemorrhage. So what happens is without surfactant, so surfactant is a soapy lipid material that creates a lining of the alveoli, which decreases surface tension. So how surfactant helps is at the end of expiration, when the alveoli are the smallest, the surfactant prevents or resists collapse of the alveoli. So with the next breath, that alveoli is easier to open, so it is going to fill with more air. You're going to have increased FRC and more air in the alveoli, which can be involved in gas exchange. But without the surfactant, the alveoli, there's going to be more surface tension, and the alveoli are going to be more likely to collapse. You're going to have less FRC, so less lung involved in gas exchange, and harder to open with each subsequent breath. RDS is more common in premature infants, and we'll talk about why. And it's even more severe in very premature infants, so babies below 34 weeks, in particular, those babies born less than 32 weeks. Both, like I'd mentioned, both blood and meconium are thought to inactivate surfactant, and so it's important to always remember to consider surfactant replacement with a severe, significant meconium aspiration child or a child who's been exposed to either maternal or fetal blood via a swallowing of mom's blood or a pulmonary hemorrhage at the time of birth. So symptoms of RDS typically present in the first few hours of life. The symptoms worsen typically over the first 24 to 48 hours. This is kind of the main differentiating factor between RDS and TTN, because A baby who is born with TTN is often the worst they're going to be in the first few hours of life and gradually improve over 48 to 72 hours. Whereas a child with RDS is going to gradually worsen over the first 24 to 48 hours and begin to improve after 48 to 72 hours. So that's why the time course can be important. So native surfactant production typically begins around 72 hours of life. So any baby, regardless of gestational age, even 24 weekers, begin to start making surfactant at about 72 hours of life. Now, the older a child is, they will make it faster and they will turn it over faster. And so a baby who is born, say at 28, 30, 32 weeks, while they still might make surfactant at 72 hours, they are not going to make enough to oftentimes support them through. And so they may need multiple doses of surfactant replacement. And it's important to remember that surfactant replacement is only meant to provide a temporary pool of surfactant. Once you give surfactant, it's probably typically used up within 6 to 12 hours after replacing it. And so you're really just using it as a bridge to when the babies begin their own native surfactant production. So again, neonatal respiratory distress syndrome, it's caused by a deficiency of lung surfactant. You get alveolar collapse and non-cardiogenic pulmonary edema. So instead of filling with air, the alveoli fill with fluid. It presents primarily with hypoxemia, as opposed to TTN, which typically presents with more tachypnea, grunting, retractions. The hypoxia is almost always worse in a baby with RDS compared to TTN, and oftentimes can lead to respiratory failure, so requiring either nasal CPAP, bubble CPAP, high flow nasal cannula, or potentially intubation and mechanical ventilation. The risk is much higher in babies born below 28 weeks, but there is still a significant risk in babies born under 34 weeks. And in particular, there seems to be a higher risk of babies born in that late preterm stage to moms who have diabetes, because there is some thought that the persistent exposure to hyperglycemia creates a hyperinflammatory environment for the fetus, which limits the production and efficiency of the surfactant turnover. And this is a nice diagram looking at how surfactant works. What you're looking at here on that kind of horseshoe-shaped structure on the left is an alveoli. Surfactant is made by type 2 pneumocytes. Type 2 pneumocytes are not expressed on the surface of an alveoli until typically around 24 to 26 weeks and reach maturity at around 34 to 36 weeks. On that kind of right cutout that is zoomed in, what you are seeing there are phospholipids that will line the surface of the alveoli, in addition to surfactant proteins. And so surfactant is made up of primarily phospholipids, which is about 70-80% of it. And then the proteins are really important for the holding together of the phospholipid bilayer. So they create a tubular myelin mesh that holds those phospholipids together, creating that environment for the reduction of surface tension by expelling water from that phospholipid bilayer, which allows those alveoli to work to open and close more efficiently. This is a really nice diagram of an X-ray, so a typical X-ray of a child with RDS. And what you're going to see are kind of the three hallmarks of RDS on X-ray, which is one so like hypoaeration, or the lungs are not going to be as open. And so you're oftentimes only going to see potentially 6, 7, 8 ribs of lung open. You're going to see air bronchograms, which are nicely displayed in these black arrows, which are specifically, you're seeing air primarily within primary, secondary, and tertiary airways, but not within alveoli themselves. And that's what gives you that air bronchogram, because air is pushed down into those secondary and tertiary airways, but because of the high surface tension in the alveoli, the air cannot get in there. And so the only air you're going to see is within those smaller secondary and tertiary airways. And then just a diffuse ground glass appearance from collapsed alveoli. Here is another very severe case of RDS. And again, this X-ray really highlights that ground glass appearance. So one of the mainstays of treatment of RDS is the replacement of surfactant. And there are several different types of surfactant on the market. I threw this chart in here just for reference for everybody because it gives you the manufacturers, the sourcing, and then the dosage. In particular, the dosage that's going to be most important to y'all is that dosage on the far right within the parentheses. And the three kind of primary surfactants that we use day to day are going to be Survanta, CuraSurf, and Infasurf. But there are several other types. They are either synthetic or from bovine or porcine origin, so from cows or pigs. It's important to remember that for some of our Jewish and Muslim families who are kosher, they will oftentimes ask us to not use the porcine derived version from CuraSurf. And so you might want to, in that case, think about using Survanta, which is bovine derived, or Infasurf, which is also bovine derived. There also seems to be a difference in the manufacturing process, specifically because the surfactant proteins within the different types of surfactant or different manufacturers of surfactant are not actually created equal. And so there seems to be somewhat better efficacy of the surfactant when using CuraSurf or Infasurf compared to Survanta. But the volume of Survanta is higher, and so you actually get better distribution. And so it just depends on what your center uses and what you like. Our center here actually trialed CuraSurf for about 2 years, and we didn't really see any difference. We were still giving repeat doses as often, whether we use CuraSurf or Survanta. And we feel like the higher volume of Survanta is actually allowing the surfactant to get more places. And so even though Survanta is thought to be maybe a less efficacious version because it has very little surfactant proteins. It is almost all just the phospholipid component. But it is the highest volume of them. And so that seems to help. And so next that we will see sometimes on transfer is congenital pneumonia. The signs and symptoms almost always mimic TTN or RDS, in particular RDS. It is almost always due to the transplacental spread or aspiration of infected amniotic fluid. It should be on your differential if respiratory distress persists beyond the typical time course of TTN, or you get minimal to no response from surfactant replacement. It accounts for significant morbidity and mortality, especially in developing countries. At autopsy, pneumonia has been diagnosed in 20 to 60% of stillborns. So there's some thought that early perinatal spread of organisms through the infected amniotic fluid can be potential cause for a stillbirth. The primary bacteria in congenital pneumonia are nowadays, after GBS prophylaxis has become almost universal in the United States, are E. coli, Klebsiella, Enterobacter, Staphylococcus, and Listeria. And so that's helpful to be mindful of when you're choosing antibiotics. And herpes is also a potential cause of early viral pneumonia. Bacterial pneumonia and viral pneumonia, when thinking about a neonate, are almost impossible to differentiate between from a symptom or x-ray standpoint. So if there's any concern whatsoever, antiviral coverage can be potentially needed. Here are two x-rays showing really highlighting the difference between neonatal congenital or congenital pneumonia and pneumonia that we see in slightly older kids, a few weeks old, a few months old. Older children tend to have more lobar or focal pneumonias, neonates typically do not have focal pneumonias. They have a very diffuse, homogeneous, multifocal pneumonia. But as you can see, it can become difficult. In both of these x-rays, you see that the pulmonary, there's quite a bit of pulmonary congestion in both of these x-rays. And so that sometimes can make us think about TTN. So it can be difficult to differentiate. That's why the time course of symptoms can be so important. And really, the important thing to remember about this is if you think there's possibility for an infection, start antibiotics early. But if a baby gets better, stop them early. And that's really our approach. And so the treatment of congenital pneumonia, you manage the respiratory status like you would any other baby, including the possible need for intubation and mechanical ventilation. Antibiotic selection should really mirror that of neonatal sepsis. And so by that, I mean typically AMP and GENT in the first 7 days, and then a different choice for antibiotics after that when you really transition from thinking about early onset sepsis to late onset sepsis. And then the factors to consider when choosing antibiotics or antivirals. So are you early and late, meaning are you under 3 to 7 days? Are you over 7 days of life? Is the baby preterm or term? Typically, premature infants need broader coverage compared to term infants. And then if you have the presence of central lines in a baby who's a few days old, you may need to cover for MRSA infections because of that possibility. And that would be more of a late onset sepsis picture with hematogenous spread of skin flora into the bloodstream and then into the lungs. And then a maternal history of herpes would really set off alarm bells for the possible need for at least empiric acyclovir and then testing to rule it out before you remove that empiric acyclovir. Another common respiratory syndrome that we see on transport is meconium aspiration syndrome. It is most common in near-term, term, and post-term infants. It is associated with inactivation of surfactant, and the symptoms are very similar to RDS. You can get meconium aspiration, a lot like RDS. The most prominent symptom is almost always severe resistant hypoxia. So no matter what you do for the infant, they remain profoundly hypoxic. That should lead you to highly consider a possible meconium aspiration. The one big fear that we always have with meconium aspiration syndrome, because of the profound hypoxia, is it can lead to pulmonary hypertension, which further worsens the ability to adequately oxygenate an infant. It can lead to the need for high frequency ventilation and potentially INO to attempt to vasodilate the pulmonary vascular bed and decrease that pulmonary blood pressure. And then in very severe cases, ECMO can be used as a possible rescue therapy. The most important thing to consider for meconium aspiration is early transfer to a higher level of care. And we here at UMC have access to even the approach for very early transfer. I would rather send a kid to an ECMO center looking at syndrome. On the upper left, you can see a baby in the uterus who is surrounded by clear amniotic fluid versus those in fetal distress in the uterus surrounded by meconium. And so what you get is sudden gasp by the baby can cause amniotic fluid and meconium to surge. It's a profound response, which fills the fluid of lung, the lungs with meconium and lymphatic and interstitial fluid. That inflammatory state inactivates surfactant and leads to profound hypoxia. This is really a a nice X-ray showing meconium, and that really those really obvious kind of pinpoint opacity spread throughout the lungs, in particular in the bilateral lower lobes. Those kind of like white stippled areas are really indicative of meconium aspiration. Here's another one that again shows those kind of pinpoint white dots or kind of white circles spread throughout the lungs that are showing meconium aspiration. And interestingly, blood aspiration is looking the same way as meconium aspiration. There's also some suggestion before disease. And so that leads us to syndrome, which is airlick syndromes. So 1 to 2% of all live-born infants vast majority of them have mild symptoms. And your airlick syndromes include pneumothorax, pneumomediastinum, interstitial emphysema, which is really more a disease of very premature infants. One of the thorax is all the lights off in the room. Use a light. Light works best, but the light on your iPhone will work as well. Kind of place it. I like to place it under the scapula, and or just kind of just lateral to the scapula, and you can that in the chest, whereas on the here's another picture that you can sort of see, kind of a good spot to transilluminate, and you can actually see that light transmits all the way up the chest and then towards midline, and is actually lighting up all the way to that child's sternum. And here is I threw this X-ray in because it's really subtle. There are actually a right basilar, or so there's a small right pneumothorax on that base. And this is you see, this baby in particular was completely asymptomatic. It was found, and it was an incidental finding, and that left lung is completely collapsed. You can sort of see the outline of that left lung, and the majority of the left chest is filled with air. This is likely going to need some type of intervention pretty quickly, depending on the child's symptoms. And again, here is this X-ray is showing a bilateral pneumothorax at the bases. And neither of these are under tension. And this child was actually just mildly symptomatic from these. This is showing a right-sided tension pneumothorax immediately after placement of a trocar chest tube. I wanted to throw this in because this kind of differentiates the different types of chest tubes that we use. So this is a trocar chest tube. This is what is called a pigtailed chest tube. You can still see that there's still some residual anterior and basilar air after placement of the chest tube, but the heart has moved back into the midline. The easiest way to kind of look to see if you're under tension or not is to look at the mediastinum, and in this case, look at the airway. and you can see that the ET tube is running primarily that is air within the mediastinal area. It's often asymptomatic, as long as it's not associated with pneumothorax. In rare cases, the air can dissect into the neck and cause subcutaneous emphysema, which is felt as crepitus in the face, neck, and supraclavicular areas. And the treatment in the case of pneumomediastinum is almost always supportive. And so this is a really nice case of pneumomediastinum. You can see air within the middle section of the chest. This child, in this case, is intubated, but you can see those kind of air pockets in the central chest. Pneumopericardium is rare and serious, and is a true medical emergency. Dissection of it's section of leak air through the vascular bundle of the great vessels, so the aorta and pulmonary artery. The reason why it's a medical emergency is because the trapped air can expand, pushing on the ventricular walls, both right and left ventricle, causing cardiac tamponade, and getting rapid decreases in venous return and sudden cardiac failure. Symptomatically, you get a narrow pulse pressure with an air leak. And in all cases of pneumopericardium, you need to consider urgent transfer to a higher level of care, in particular a cardiac. Picture of cardium. Thankfully, I've only seen this once in my career, and it was after cardiac surgery for a baby with congenital heart disease. This is kind of our last air leak, which is pulmonary interstitial emphysema. So you see it in the typical presentation of pulmonary interstitial emphysema is in a baby born very premature who has been on mechanical ventilation for at least a few days, if not longer. It is related to prolonged exposure to barotrauma. The trouble with pulmonary interstitial emphysema is that it requires increasing amounts of respiratory support, which can expand the cyst and compressing healthy lung tissue. One of the mainstays of pulmonary interstitial emphysema treatment is high frequency ventilation, whether on an oscillator or through a jet. And so for air leaks, really the treatment depends on severity. In asymptomatic patients or in patients with mild respiratory symptoms, oftentimes supportive care is all that's needed. Although I would always consider transfer to a facility capable of intervention for those infants who may be mild or asymptomatic at the start, but may worsen. There is kind of this old school technique about using a nitrogen washout, so using 100% oxygen, which is thought to push out nitrogen, and theoretically, because of the density differences in the gas between oxygen and nitrogen, allows for some movement in the air leak. So when comparing 100% oxygen to 21% oxygen in multiple studies, they really found a difference in outcomes or the need for intubations, whether it's thoracentesis or chest tubes. Okay, and so lastly, I just wanted to put these so everybody has this. This is UMC's NICU's pre-transport respiratory plan of care. This is something that I would highly encourage all of you to kind of keep on hand as a resource. So I'm not going to go through all of it, but there's a bunch of really good resources in here on how to manage these babies in the early stages when you're either thinking about or planning for a transfer to a higher level of care. It discusses keeping the baby warm and respiratory support. So all babies on minimal, so the minimum support of 2 liters to maintain lung recruitment, adjusting the FiO2 to maintain preductal saturations of greater than 90, obtaining a chest x-ray and a blood gas. If the baby has persistent respiratory distress, or on that initial blood gas you have a pH of under 7.3 or a PCO2 of greater than 60, consider increasing your support or intubating, depending on what you feel necessary. So options for increasing support are bubble CPAP, more liters on high flow if that's available at your center, or if you're already on gas intubation. For intubation, we always recommend using uncuffed ET tubes, and we listed kind of sized and ET tube depth here in a nice chart to keep for reference. Checking following intubation using an in-tidal CO2 detector, using auscultation, looking for mist in the tube, looking for bilateral breath sounds, and an improvement in the respiratory status. If you are after intubation, if you are managing the baby with bag mask ventilation via PPV, aiming for pressures of 20/5, so a PIP of 20, a PEEP of 5, or slightly higher depending on how much chest rise you are getting, and then rates of 30 to 60. Here are also some recommendations for initial ventilator settings to keep on hand as reference. And then there's some documentation here for adjusting ventilators after a post-intubation gas, just to kind of help guide adjusting that ventilator to get the gas in kind of our target ranges for pH and CO2. Here, there are also some recommendations here listed for when and how to give surfactant. The other thing I would also say is that if there are ever any questions, even if you're, haven't decided on transferring yet or transferring somewhere else, if you have a question, just call us. We're always happy to help, regardless of the situation. And there are some suggestions here on how to manage fluids and how to think about potential access points. So whether that be an IV, a UVC, and then some recommendations here on how to start fluids and what fluids to start and how to adjust those based on the baby's glucose. Because it's really important, to keep these babies warm and keep their glucoses normal. And then some target blood pressures. And that is all I have. And I'm happy to answer any questions that anybody has.
Could you go back to the second slide? After the environmental slide, that second slide.
Of course. Of course.
So I didn't get.
Of course.
Thank you.
This one?
Is that the second one?
Yes, ma'am. Here's the environmental, and there's the second one.
Okay, perfect. Thank you.
And I'm sure Kelsey can send this out to anybody in document form if it would be easier to get it that way.
Yes, sir. Thank you.
And if anybody wants the slides to share them with their nursing staff or anybody, just let us know. I'm happy to share whatever we have with anybody who wants it.
If you want to add your email in the chat, I can send out the slides as well as the pre-transport respiratory distress plan.
Did you need the next page as well, ma'am?
No, sir, I was able to catch that one. I just missed the in-between.
Sorry, I know I talk fast.
Thank you so much, though. It's really great information, especially for us smaller hospitals. We always want to make sure that we're doing the best until transfer can get here.
Yeah, we're always happy to help in any way we can. I mean, we've stayed on the phone with people for hours if necessary.
In the meantime, I'm going to send the link to the evaluation CE credit. Go ahead and fill that out, and then I will start distributing everybody's certificates to them in the next couple of days. Thank you guys this morning. We really appreciate it. Like Sorrel said, we're always happy to help and share resources in any way that we can. So if you think of anything or think of any ideas or education points that you feel would be helpful to your facility or your population, always feel free to reach out to us, and we're happy to help put something together.
Thank you, everyone.